thanks everyone for joining us today. I'm Jenny Hornick. I'm the digital marketing specialist here at JMIR Publications, and I'm very excited to welcome you to our monthly JMIR Mental Health and Society of Digital Psychiatry webinar. Today's topic is bringing digital mental health to county services. And we're going to discuss the challenges and the opportunities that come with that. So we'll dive into this in just a moment, but before we do, I just want to go over a couple of housekeeping items. So first off, you'll notice that all of your microphones are muted. They do stay muted for the duration of the session, but we also do encourage that you ask the speakers any questions that might come up during their presentation. You can do this by using the Q&A box that you'll find towards the bottom of your screen. And additionally, we are recording the session and we will be sending the recording out to all folks who registered. So you'll have the chance to watch it later or share it with colleagues who might have not been able to attend. And we also share the recording on YouTube. And yeah, that's all for me. So I will go ahead and introduce Dr. John Torous, and he will introduce today's speaker. So Dr. Torous is the director of the Digital Psychiatry Division at Beth Israel Deaconess Medical Center, which is an affiliated teaching hospital of Harvard Medical School. He's also, of course, the editor-in-chief of JMIR Mental Health and the co-founder of the Society of Digital Psychiatry. So without further ado, I'd like you all to join me in welcoming Dr. John Torous.
Excellent. Thank you, Jenny, and to JMIR. We have a fascinating talk today, and we're joined by Dr. Stephen Schueller. He is a professor of psychological science and informatics at UC Irvine. He received his bachelor's degree in psychology from University of California, Riverside, and his doctoral degree in clinical psychology at University of Pennsylvania. He completed his pre-doc internship and postdoc at UCSF, and then did fascinating work at CBITS with Dr. David Moore, and now runs a very dynamic team doing implementation, development of tools, development of standards across California and really the world. I think the best way to introduce him, at least from a JMIR point of view, is as editor of the journal, I get to see who people suggest for reviewers, and Stephen Schueller is the single most requested reviewer on papers. And that's an honor for Stephen Schueller, but that means you should not request him to review your paper because he cannot review half of every single paper submitted to the journal. That would be more than a full-time job. So he's clearly someone I think many of us have heard of. He's done fantastic work. You've probably seen those projects he's done and efforts. But I think what's exciting is having him tell us a little bit about different implementation efforts he's done. He's one of the few people that's actually done implementation training and is also in digital mental health. So it's a card-carrying implementation expert from a fellowship. But with that, Stephen, I'm going to hand it over to you to kind of give us a background about what you're seeing in the space, some efforts, and we'll have a conversation and open it up for questions.
Awesome. Well, thanks, John, and thank you to JMIR and the Society for Digital Psychiatry for the invitation to come talk. So I'm going to provide just kind of like a very broad overview of some of the things I see in the field, and then talk about some specific work that me and my team did in evaluating a project that was here in California, before me and John have a little bit of conversation around some of the like real challenges and opportunities we see in this area. So, probably not surprising to this audience here, being readers of JMIR Mental Health and, following the Society for Digital Psychiatry. Digital mental health is here. It's been around for quite some time. John and I were talking a little bit as we kind of came on about just how long, we've been around in this field and what we've seen. And I started my first digital mental health project 20 years ago, where we were putting PDFs and PowerPoints on websites. And that was the state of the field, and we've come a long way since then. So this slide just demonstrates some of the funding and the interest that's come from the venture capital space for a report that's come from Rock Health. And you can see in 2020, it was up at $2.4 billion. Places around the world are using these tools as frontline treatments. This is a newspaper front page that comes from the London Times. Doctors to give sleep app rather than pills, and this was related to some NICE guidelines around the use of Sleepio as a sort of frontline treatment in their talking therapies program there in the UK. So lots of places around the world were using these tools as frontline interventions. But digital mental health is not without their challenges. It's not so simple to just build a tool and put it out there on the App Store. If you build it, they won't come. It's not the case in the digital mental health space. We really need to think not just about developing these tools, demonstrating they're efficacious, but how do we actually kind of move them in responsibly to different settings where people might benefit from them. I'll also say, again, it's not without other challenges. So there was a project where Talkspace where Reno purchased Talkspace for its residents, and after some time in terms of the project and millions of dollars, they found that fewer than 1,400 people were actually taking advantage of the city's deal. Very few people signed up for it, even though it was available and present for them. This figure comes from work that Greg Simon did in the Mental Health Research Network, where they deployed a digital dialectical behavior therapy tool for individuals who are at risk for self-harm and suicidality. And what they found was over time that the people who received the digital tool actually did worse. They had more reports of self-harm thoughts. They had actually higher mortality than individuals in the care management or the usual care condition. Now, I think an important caveat or important thing to kind of dig into that data, people actually didn't really use the tool much. There was not a lot of engagement with the digital tool. So it's not about, I think, like the harm of the tool itself, but thinking about how we fit this tool into different service settings. When someone's at their worst and at their lowest point, handing them off to a digital tool versus connecting them with a human and care connection is maybe not the most effective thing. And so I think we have to think about the negative externalities of these tools, not just from like the content and what's in the tool. John and I have looked at thousands of these tools over the past decade, and we can tell you there are a lot of content that's probably concerning these tools. But even a good tool, an efficacious tool, if put into the wrong place in the system, could also have other potential harms as well. At the same time, mental health systems are adopting digital mental health solutions. And this comes from a paper that came from the Kaiser Group in their Kamai project as they were thinking about sort of integrating different digital apps into the Kaiser ecosystem. And one thing I want to note here, kind of nodding to some of the implementation science aspects that John talked about, is that when I see their sort of pathways and I see what they're sort of focused on, I think about this in terms of some traditional sort of aspects of implementation science, and this is just mapping onto the Consolidated Framework for Implementation Research. It kind of boils down to there's people, there's places, there's processes, and there's interventions that we're kind of thinking about. And these, I think, are the core elements to often consider as we think about implementation considerations there. I also want to kind of shout out a recent paper that John and colleagues wrote where they talk about the importance of building and I love this word, a sustainable digital mental health. So it's not just about putting things out there, it's making sure that it's sustained and it's maintained. And, as they say here in the title, his words, not mine, it's prime time for implementation science. We really need to think about how we can move these tools when there isn't evidence base for them into routine care settings. So one concept I think is really important in implementation science, and this comes from a paper that is widely cited, although maybe not for this specific quote exactly, but this is Jeff Curran's sort of classic paper now on hybrid effectiveness implementation studies. So these are studies where we evaluate implementation questions at the same time as effectiveness questions. And these have become very common in mental health research. Actually, the National Institute of Mental Health has 2 open funding mechanisms that requires investigators to use hybrid effectiveness implementation designs as they're proposing their projects. But one thing I really draw from that paper, and I want to kind of point out, is the question of like, well, why would we look at implementation and effectiveness at the same time? Why would we implement something when we're not entirely sure it's effective yet? And they call out that there are times when there is a momentum for implementation. And I would argue that right now we're in a current moment where there is a tremendous momentum for implementation for digital. So they say in the paper, where health systems actually encourage or attempt implementation of a clinical intervention without the desired clinical effectiveness data, strong indirect efficacy or effectiveness data, advocacy from patient groups, providers or lawmakers, and administrators seeking to reduce costs by implementing a cheaper clinical alternative. I think a lot of this applies to where we are in the current state of digital mental health. There are tools out there that there is maybe some strong indirect evidence, but not direct evidence. There is desires to use these for specific sort of cost effectiveness benefits. Sometimes different advocacy groups are really clamoring for digital solutions. And so I think there's a lot of places where we're seeing a desire to implement when we don't have the strong clinical effectiveness data we would want. And this really calls for designs where we can think about understanding the implementation considerations at the same time as we're generating evidence for effectiveness. Okay, so I want to shift gears and talk a little bit about a specific sort of project that my group was engaged in over the past couple of years. And I want to provide a little bit of framing of California because it's kind of an important aspect of this project. So back in 2004, California voters passed what was known as the Mental Health Service Act, or Prop 63. In 2024, it was rebranded to the Behavioral Health Service Act with Prop 1. Changes a little bit about how the dollars are used, but essentially this is an earmarked tax where everyone in California who makes $1 million or more per year, 1% of their income is taxed and dedicated to mental and behavioral health services. And this has been a quite big amount of money over the past couple of years. So from fiscal year 2022 through fiscal year 2025, you can see it's been around, just over or just under $3 billion. This is great for the state and great as an opportunity to really think about innovative mental health solutions. One sort of bucket of ways that these dollars could be spent under the Mental Health Service Act was innovation projects. These are projects that are really meant to try something new to produce learnings that could benefit the mental health system. And these dollars flow through the counties. So one thing that is also unique about California, or maybe not completely unique, but different from other states, is we effectively have 58 different mental health systems in our state. So back in 2012, California shut down its Department of Mental Health, with some of the staff moving to the Department of Healthcare Services. But what that means in California is we don't really have a centralized mental health leadership. The mental health leadership is really decentralized through a county system. And if you've seen one county, you've seen one county. These counties often operate quite separately from each other. So that actually makes the project I'm going to talk about here, I think, even more unique because it really is a sort of indication where counties came together to try to work together to produce some learnings in a specific project. So this is a project called Help at Hand. This was a 14-county collaborative project that lasted from 2017 to 2024. There were 3 components of types of digital mental health solutions that were implemented through Help at Hand. And these are sort of broad buckets, and we could talk about what the actual interpretation, what these things mean. But they were either digital solutions that offered peer chat, virtual evidence-based therapy using an avatar, or digital phenotyping using passive data for early detection and intervention. So, a variety of the different things that technology could do in the mental health system. The counties really interpreted these things in a variety of different ways. These were the counties that were represented. I have them colored in sort of 2 sets. So the blue counties are the cohort 1 counties. These were the first counties to come on. Orange, Los Angeles, Kern, Mono, and Modoc. And then the yellow counties were the second cohort counties. So these followed about 6 months after sort of the initial set. And you can see that they implemented a variety of different technologies: 7 Cups, MindStrong, Headspace, I Prevail, MyStrength, A4I. They also, a lot of the counties built programs around the technology. So they did a lot of digital literacy training, following the model that John's developed for some of the different training that he's done. So a lot of different aspects got implemented as part of this project. I'm just going to provide some very high-level takeaways and point you to some papers that you can look at if you want some more information on this. But one thing we learned was that successful implementation requires readiness at multiple levels. To go back to that see-first sort of idea, it's not just about the intervention or the people or the processes. You got to think about all those different levels. And so we talk about these in a paper that Alyssa Zhao led in JMIR Formative Research. That's at that black QR code there. and then the Bibliotral-led that was published in Administration and Policy and Mental Health Services research that looks at this from a peer perspective. Um, Products were often impactful, but they needed considerable support for implementation, such as digital literacy training. It's not just about having an effective tool. It's about the ecosystem that you build around that, and that ecosystem often involves, human people who have to do a lot of work to get people onto the platforms, to know how to use the platforms, to do, again, some of the work that John's been showing in his digital literacy work. And we have a paper in implementation research and practice led by Rosa Hernandez Ramos at that orange QR code if you want to learn a little bit about a pilot project on the implementation of My Strength in Marin County. And then lastly, tools could provide widespread access, but not everyone was interested or needed support. There was a lot of efforts in this project to try to do sort of public health deployments and get tools out there to people maybe who wouldn't traditionally be entering the mental health care system. Several of these counties in response to COVID did a public health deployment of Headspace to try to get a resource out there. And Judith Bergeau and us, we have a paper in press now at JMIR Formative Research. You can get the preprint at this green QR code here that talks about lessons learned from that sort of wide-scale deployment of Headspace across a couple different counties in the state. And I think one thing that was really interesting about that paper is that we were actually able to follow up to people who expressed interest, but either then never downloaded Headspace or stopped using Headspace pretty early on. And I think these are often people who go unlooked at in the sort of studies that we do. When people drop off, we often don't know, like, why did they stop using it, and what did they like or what did they not like about it. And so that study has quite a large sort of sample of people who were early users but stopped. So I think a really interesting way to kind of look at that in real world settings. And that's all I have as an overview. So I will stop there and pass it over to
That,
John to queue up some questions.
yeah, that's a lot that you gave us. And I think you were, if not the first, one of the first people telling us to think about implementation of these tools in the ecosystem long before it became well known. For junior people starting in the field, sometimes you kind of look up implementation science frameworks and you go, oh my gosh, there's so many of them. Where do I start? Is there kind of one starter? There's no perfect framework, but like, is there one framework you think people should like use to begin their journey to understand, or how do you get into this
Yeah.
important but complex world?
Well, I mean, I definitely think us implementation scientists don't make it easy because we love our frameworks and theories and models. We love our jargon. I do think it's really helpful to sort of think about like what you're trying to do with that framework, because there's even different types of frameworks. There's determinant frameworks that try to tell us about the factors that influence implementation, like the CFIR. There are evaluation frameworks that talk to us about how do we measure implementation outcomes, like Russ Glasgow's RE-AIM or Anola Proctor's framework. So I think the first sort of question I encourage people to do is think a little bit like, what do you need a framework to help you do? What are you interested in learning about? I really like the CFIR as a determinant framework. We use the RE-AIM and the Proctor model for a lot of our outcome models. The University of Washington actually has a really beautiful page for their implementation science group. If you Google like University of Washington implementation science frameworks that go through these different type of frameworks and have some examples. But I do think, I really encourage people before they kind of dive into the frameworks to just like really think deeply about what is their research question? What are they trying to learn? I think that's something that is really useful for junior people in a lot of places, is just having a lot of clarity around what's the research question you're hoping to answer in a project when you take it on.
Yeah. Those are useful resources also too, and a good framing of how to approach it. We talked a lot about, again, different tools have come and gone. They don't seem always stable. Do you think are we at a point where we have enough tools and we just need better implementation, or is there that killer app and that one tool that's going to rule them all, and we're
Well,
just waiting for it? This is a hard
there, there-
question.
there's no killer app to rule them all. I will say, and this is maybe an unpopular take, but I can take it. I guess I can be an unpopular guy at times. I'm a little bit worried about the way the field is going, and that I see a lot of these projects and researchers, and like I've done this too. So, I'm not trying to wag my fingers at you guys. Like I think this is but where we do like a lot of really thoughtful co-design and like a lot of user engagement, but we're focused on a very specific population. And I really worry about this approach where we're going to build like 500,000 different tools for 500,000 different sort of unique populations. Like, I don't think we need, a tool for for Latino youth in Boston, and then we need a separate tool for thinking about the sort of unique characteristics of an LGBTQ teen in Southern California. There's got to be a balance. And so I think one thing that I've been thinking about, and we're trying to do this in a project we have right now funded by NIMH called Supera, is how do we kind of create like the good enough digital intervention or tool, and how do we think about the sort of human engagement wrapper around that? And I think that aligns with some of your digital literacy components. So I think we need a set of kind of good enough tools. And I think that we need to think about how the people are able to help contextualize and adapt it for sort of context. And so that doesn't mean we don't need to partner. I'm not saying like, let's not partner with
Yeah.
communities. Let's not understand what communities need. But I think the approach of really trying to build like these like unique tools for like very unique populations, I just don't think that's scalable. And so I think we kind of need to think about how do we sort of balance, the set of good enough tools as you talked about. So I think
Yeah,
that's an aspect.
I'll join you in being somewhat unpopular. So I wonder if even the self-help app is dead. It may have never truly existed, or if we can bring it back to life, not by adding better gamification or better AI to it, but better implementation is customized at the community level. So they still have, we're
Mhm.
co-designing, but maybe we move it up from the tool to where it moves from. It sounds like that's what you guys are doing with this project in some ways.
Yeah, and I think there's still an open question of like whether, like I would maybe push back and say the self-help tool is dead, but I think it's important to figure out like who benefits from that. Like, so we have some data from a project and it's, early on, so, take it with a grain of salt. But like to suggest that there's a subset of people that actually the coaching support in the follow-up period seems to be less good for them. So that like if you look at like just the after intervention outcomes that they do as well, but if you look at like 6 months later, if they had coaching, they do less well than other folks. And like some of the theory or some of what we're thinking about this is like for people who are like really well motivated and could do this on their own, that if you have the coach there, they're sort of thinking about like, well, it wasn't me that did this, it was the coach that did this, and now the coach isn't there, and maybe they're not as engaged or as interested. I don't know, but like there is, I think, a question about the people really who are motivated and can do it by themselves, whether there could be some aspects. And I think that also speaks to, I think it was an early study from Gerhard Anderson where they found that like people who were randomized to technical support did better even if they didn't get that technical support. So just knowing it was there, was useful for
Yes.
them over the people. So there's no difference in the use of support between the unsupported and the supported people, but so there's still a lot of support I think we need to unpack and like understanding the role it's playing and what people are doing. But I think that I would say just as we talked about there being no one app to rule them all, there's probably no one model of support to rule them all too. And so we need to think about sort of flexible models of support that fit these things into continuums of care.
Yeah, and you said clearly there are cases where self-help app will be transformative for a person. There's cases where great design at an early stage will make a difference. But at a population level, I agree. We
Yeah.
probably need to think of moving it. And that's what's nice about your work is you're kind of looking at a state that's bigger than most other states combined, or some countries.
Yeah.
In
I think even our county is bigger than some other countries here in Orange County. So we
yes.
definitely have a big playground here in California to test these things.
Maybe I'll open it up to audience questions for just the next 10 minutes. We have a couple good ones. And the first one saying, can we elaborate on hybrid implementation approaches? Sometimes it's named as like a hybrid type 1, it's a hybrid type 2. And how do you know you actually got it right in a hybrid study? Because you're looking at, did it work? Did it implement? So maybe just a quick overview on
Sure.
or
Yep.
detail of
And
hybrid implementation.
so as John alluded to, there are sort of three types of hybrid studies. There are type 1s, type 2s, and type 3s. And a hybrid study is it's a research study where you are simultaneously asking questions about implementation and effectiveness at the same time. So hybrid type 1 is a study where it is preferencing the effectiveness questions and sort of piloting the implementation questions. A hybrid type 3, I'll jump to that one, is one that is an implementation study. So it's preferencing the implementation questions and kind of piloting or collecting, less rigorous data on the effectiveness questions. And then hybrid type 2s are studies where you are simultaneously asking an implementation and an effectiveness question. Um, and so I think like the answer of like, well, how do you know you got it right is like, well, it kind of depends on what hybrid you're doing and what question you're trying to answer. Like if you're doing a type 1 hybrid, you're really just trying to collect some information to kind of pilot the implementation. You're trying to understand some of the contextual factors that might be present there or aspects of some of the implementation processes that might help you develop a formal implementation strategy that you can test. In a hybrid type 3, these are pretty hard studies to do, and I would say they're the most rare types of hybrid. You usually only can do a hybrid type 3 if there's like some data that's present in like the ecosystem to be able to like get some effectiveness data or some signal for that. So for example, if you're like implementing a new digital mental health platform in a healthcare setting, and testing the implementation strategies, but you can like collect some information about patient level data from the electronic health record. It's not the most rigorous test of effectiveness, but it can give you some signal of whether this is working or not. The study actually alluded to earlier that we're doing with that sort of human engagement wrapper, the Supera study, is a hybrid effectiveness type 2 study. So we have an effectiveness question, which is, does this community peer-supported digital cognitive behavioral therapy work better than the self-guided digital cognitive behavioral therapy? That's an effectiveness question. And then we have an implementation question that we're looking at because we're implementing it in safety net primary care settings, which is, does it work better to do what we're calling outreach versus inreach? So outreach is a direct-to-consumer approach. We don't go to the EHR and we find people who might be eligible and we kind of contact them directly. And inreach is a sort of traditional clinic referral warm handoff. So we're working with the behavioral health teams in these different settings. And we're looking at like, do we get differences in terms of reach or representation? Is it the same type of patients we're getting from each of those approaches? I'll say right now, what we've learned from like early stage stuff is that we've been able to reach more people with the direct-to-consumer approach. But that population tends to be a little bit less severe, a little bit more tech savvy. Whereas if we're working through the clinics, we're getting a slightly more severe population, people maybe who wouldn't be turning to technologies by themselves. So, I think that and so what we're learning is very different in those effectiveness aspects and those implementation aspects. So I think, if you ask the question of like, how do you know it's working, kind of depends on which part of it you're thinking about, the effectiveness aims or the implementation aims.
That's a nice example to also see both of them in real time or as you're doing it. A different question, again, hard one to answer, says, what is the clinical efficacy standards you would want to have as kind of a minimal baseline that these tools need to have to establish they're going to be sustainable? So is there some way that we know these tools are good enough to be sustainable, or do they have to work so well before we think they're sustainable? So it's kind of mixing, when is a tool clinically useful, and does that tell us it's going to be sustainable, as we talked about? So that's a tricky one, because I think each of those questions alone is tricky. It's like,
Yeah, and I think another,
sustainable.
I'm going to make it more challenging first, and then I guess I'll try to answer it. But I'd also be really curious on your thoughts, John. But I think there's a lot of times I've seen people make the case that like even small differences in these digital mental health interventions are clinically meaningful because they're so scalable, they can be at a population level, which I understand. But also on another hand, so I do most of my work in depression and anxiety. And if we improve everyone in the population's like depression by like a half point on the PHQ, how much do we really care about that? I don't know. I mean, so everyone's a little less depressed. I don't know. I'd rather be able to like get the people who are really struggling and move them more points. And maybe that's happening with these tools. But I do think like the argument that like small effect sizes are really meaningful because it's spread over an entire population is important to think about. Like, does each individual person really care about that
Yeah.
sort of, individual difference. And, I've heard this argument in non-mental health areas as well, like weight loss. It's like, everyone lost a pound. Isn't that great? It's like, maybe, but how much does everyone care about a pound difference?
And in digital health, we don't know if everyone's actually going to get that exposure. Like we hope they are in a population, but as we
Right.
know, not everyone engages. So I agree. That's a tricky, it's a tricky
It's a
one to make
tricky
that.
argument to make. I think if we're shifting or thinking about population level, I think rather than thinking so much about like small effects on these clinical outcomes, I think trying to take more of like also a wellness perspective and a prevention perspective. Are we stopping people from having to get to services? And that they're not, prevention and early intervention. But I do think we need to think carefully about the argument of like small effects over large populations.
Yeah.
Um, I do think one of the challenges with the mental health space is that mental health services are completely broken. And so, it's a system that is ripe in need for innovation. And so bringing in something that's effective and deployable, I think is like really, really key and really important. Um, I think a challenge, though, is also we need to make sure that we're considering the potential negative consequences. I brought up that sort of example from Greg Simon's work. And I think that's something that's not asked enough about in the digital mental health space because we're so focused on the outcomes we want to see. We don't ask about, what are the potential harms. So I think it's not just about clinical effectiveness from like a how does it move the outcome we're interested in, but also what potential safety concerns are we introducing in terms of a variety of different things. Symptom worsening, data, exposure, who owns the data, who's getting access to it, what privacy concerns are we doing? Potential, one thing actually that I worry a lot about is people using one of these tools, not getting better, and then not seeking subsequent care. Because, like, I tried that therapy stuff, it didn't work. I'm beyond hope. Um, so I think like when we think about guidelines, we can't just think about effectiveness. We also have to really, really think about safety.
Yeah. What's interesting, the Greg Simon study, he had thousands of people. He looked at them for a long time. So if he only had
Mhm.
like 20 people in the study for 1 week, he would not have seen it. So it's interesting too that through Kaiser, he had the resources to scale it. And we don't get many studies with like over 50 people in digital health. We're getting more,
Yep.
which is good. One thing that's worried me that we've talked about, Steve, is like, I should patent the name the Tetris test is like, is the app any better than active control, like tracking your mood or playing Tetris? So like a lot of
Mhm.
times you'll read the study, it says the app is effective against a weightless control. And you go, well, that's true, but aren't most things better than nothing?
Yeah.
And again, you get into this debate of what does nothing mean in mental health if the system's broken. But I do worry that an app that's not better, that can, if you can't beat playing Tetris, you're going to have a really hard time scaling, making people better, or even making a profit as a company if Tetris is going to eat your lunch. Or do you think that's too cynical or stringent of you?
Well, it makes me think of some work that a former student who worked with me, Benji Kavaladze, who's now about to start a postdoc with Nick Jacobson, did, where he was interested in kind of a similar thing. But his sort of idea is like there's a lot of like online content that's out there that people could find, right? You could go to
Yeah.
TikTok, you could go to YouTube, you can read blogs. And so he wanted to sort of think about like what happens if you compare, a digital intervention to sort of like online help seeking as usual. And he actually even provided like a little bit more of like a rigorous one where he had his like team of RAs go out and find, different things on the internet and he used that as a comparison condition. And
Yeah.
I think he actually was like more interested in like the flip side, which is like, hey, couldn't all this like online content be really helpful for people? And if we could just find it and harness it, that would be a good intervention. And he
Yeah.
found out that the digital intervention did better than the online content, which he was a little bummed about. But I was like, maybe this is a good thing, right? Like, because
Yeah.
this is the comparison, right? Like, if someone is, you know, searching things online, and I mean, I think we see more about this and like recent discussions around like the use of ChatGPT. If they can't get into your study and they can't get your app for whatever cost you're paying it, they're probably just going to go to ChatGPT and be like, "Yo, ChatGPT, help me out here." And I'm not advocating to do that, so please do not say
Yeah.
Dr. Schueller told me to go to ChatGPT to solve my problems. I've said lots of places I don't think that's a good idea, but that's what people are doing right now. And so I do think we have to think about like not just what is the comparison ecosystem? And I think we have pretty good ideas in clinical settings about what's treatment as usual. But I do think it's interesting to think about like what is online help seeking as usual? Is it playing Tetris? Is it going to TikTok?
Yeah.
Is it going to ChatGPT? And if you're not better than those things, then that's a problem.
Yeah, that's it. And I think we have so many more questions, but I realize we try to keep these somewhat brief in it. It's a lot there. So I think we should, as I said, break here for time because else we could be here all day and all night with it. But I think this has given everyone a wonderful flavor of kind of how to do this work at scale, how to work with, again, entire state, different counties, what to think about in doing it. And implementation science is not easy, but I think you've helped demystify it a little bit or shown us it's not only important, but it's feasible and doable. So thank you so much. And thank you everyone for listening.
Yeah, thanks for having me.
Thank you.
It was a really interesting conversation.
Bye, everyone.